Good morning. With the permission of the chair, I shall give you the presidential address, and I'm a proud person standing here to address you as the president of the ISOT 2022 to 2023. So many of you who have supported me in this journey, and I started my nephrology career in CMC Vellore along with CM Tyagarajan and other people in 1980. And the journey was unending, and it is still unending. So many of you, including Vijay, all these persons who are sitting here are my close friends. So let me start my presentation. Okay, I want to say thanks to the great statesman. I'm not a politician. I don't belong to any political party, who said one organ donor can save 8 to 9 people to get a new life. And there is a book being edited by me. It will be distributed and released tomorrow during the inaugural session. And the title of the book is 𝐺𝐞𝐨𝐫𝐠𝐢, Prime Minister Narendra Modi Saves Lives with Kidney Care. So the outline of my talk is CKD in India, early detection and prevention, live and DD transplantation current status. Are we able to preserve functioning allograft for indefinite period? So that will cover post-transplant diabetes mellitus, antibody-mediated rejection, BK virus nephropathy, graft pyelonephritis, including mycobacterium tuberculosis, transplantation and malignancy, hypertension post-transplantation, obesity and transplantation. So this is something, I was part of this article which came out in Lancet, and the prevalence of chronic kidney disease. These are the 6 regions of the world in 12 countries, and this is high-risk population. This is the general population. It is about 17.2% where we stand. So India 2022 organ transplantation milestone. We are rated the 3rd in the world, and I am extremely thankful to the lady who is sitting here, Dr. Swarnalatha, who has led the Telangana program and which came first in India in DD transplantation. We had 15,561 organ transplant, 10,000 kidney transplant, total deceased donor organs were 2,765 and kidneys were 1,585. So the question is long-term immunosuppression, tale of immediate gratification followed by frustrations. Short-term success, long-term kidney allograft survival frustratingly not enjoyed a similar rate of improvement. So Chaco already alluded to, I have the names of the people, so I am not going into detail. And then kidney transplantation, long-term management challenges are immunosuppression and monitoring, transplant complications, and special population including pediatric recipients, pregnancy, and contraception. So evolution of immunosuppressive drugs and immunology challenge. I'm using this, this we published in NDT. This is the same one which Chaco showed depending upon the use of the newer drugs and the survival of the patient. And by HLA match. Williams published the result of 198,000 disease transplants done over a period of 998 years. And it showed that if you have 1 mismatch, the survival is 12% less, and if you have 6 mismatches, the survival is 65% less. So here you see that in HLA match and the transplantation in CMC Vellore over many periods on the vertical axis, you can see the cumulative probability of graft survival. In the horizontal axis, time in months. So with a better HLA match, you have better survival. With a poor HLA match, your survival is less. Now, I'm thankful to this man who is sitting there, Hariharan, for publishing this article so that I could use it, long-term survival after kidney transplantation. So it's a little complex, but I will take you there. It shows the patient survival, living donor, 2012 to 2015, 28 to 2011, then 24 to 27, and all these. And then also the graft survival, living donor, then the patient survival, deceased donor, shown here very clearly. You know, you can even show it to a 10th standard student. It is very lucidly presented here, and then the graft survival, and then date of birth. I want you to look at that. Living donor, the percentages are different when you When you look at that, see on the left-hand side, the rate of death, and on the rate of death in the deceased donor, it is different. Look at that 4% here, it is 7%. And so graft loss is also shown in the living donor and the graft loss in the deceased donor. Thank you, Hariharan, for helping me to present this. So post-transplant diabetes mellitus decrease patient survival. Allograft survival is decreased, diabetic disease in allograft and graft loss. I'm showing our own examples. So risk factors for post-transplant diabetes mellitus are, they start from the pre-transplant period, allograft period, and post-transplant period. Non-modifiable are shown here, the race, genetic predisposition, age more than 40 to 50, and the modifiable are obesity, metabolic syndrome, and hepatitis C virus infection. The allograft deceased donor, increased number of HLA mismatches, predispose you to more diabetes, and immunosuppression, CMV infection, hypomagnesemia, and rejection episodes. So having learned that, every patient I have a periodic magnesium level check in the post-transplant period when they come for follow-up. Now, PTDCM decrease overall patient survival, steroids play a major part, CNI play their own part, and mTOR inhibitors play a large role in the post-transplant diabetes mellitus. So I'm just showing you a patient 20 years after the transplant. Transplant was done in 2003. BP currently is 130/70, BMI 24.4, on top sirolimus 1 milligram for 18.5 years. Steroid plus MMF, creatinine was 1.7, so he came for a checkup. Urine protein 3 plus, glucose 3 plus, WBC 224, RBC nil. Urine BK virus is insignificant. Biopsy, let me take you to the biopsy. So this biopsy shows 20 years post-transplant, diabetic kidney disease, afferent and efferent arteriolar hyalinosis, as you can see here, sclerosis, no IFTA. Why no IFTA? He never used CNI. So if you have been on CNI, you are going to see IFTA. See that biopsy, there is no IFTA at all. So no significant IFTA. So 18 years on rapamycin and prednisolone and MMF. So preventive strategies to prevent diabetes are more vegetables, gut dysbiosis, bariatric surgery, pharmacological approach, a glycemic target, stringent post-transplant diabetes mellitus, and insulin therapy with tight glycemic control. Novel anti-diabetic agents we use in a number of our patients, SGLT2 inhibitors, GLP-1 analogs, DPP4 inhibitors, metformin, which is the cheapest, and immunosuppressive modulation. So viruses and the kidney. BK virus nephropathy, asymptomatic viremia in 10 to 30%, destructive BK virus, allograft nephropathy 5 to 6%, BK nephropathy, graft loss 10 to 80% in infected kidney. The modalities are reduced immunosuppression, biopsy pathologic diagnosis, risk clinical management, intra-kidney distribution is patchy, so you have to be very careful and discuss with the pathologist in person rather than sending a biopsy to somebody else and they do not know what it is and you are totally in confusion. So when you take the biopsy, this is something which I knew. You should have cortex as well as medulla because the BK virus concentrates on the medulla, but you have only cortex, you won't see the BK virus. Let me show you an example. This is a girl, young lady who had a transplant from her mother. Initial creatinine was 0.73 milligram, rose to 2.83 milligram on triple. Initial induction with single dose of thymoglobin because she had some 1 milligram per kilogram. I don't use more than that. Jeremy was telling me you don't even need 1 milligram. You need only half a milligram per kilogram body weight. So we need to tailor our immunosuppression rather than using 4 milligram per kilogram body weight. So what you see is you don't see BK virus on this. It only shows interstitial inflammation. So no viral inclusion seen. And BK virus count in the blood was very high, and BK virus count in the urine was this, and reduced immunosuppression, and she is continuing on leflunomide. So this is an area where they thought that probably there will be some BK virus, inclusion sitting in the kidney biopsy. So co-infection of BK virus and cytomegalovirus in transplant recipient. This is one of the patients, who had both co-infection with BK virus and also CMV. So this is recurrent renal allograft dysfunction due to urinary stenosis in a patient with BK virus infection. You can see that, so we had to take care of it, and in the proximal part, this hasn't been reported. Most of the BK virus gives rise to the ureteric stenosis where the anastomosis is done. So hepatitis B virus and kidney. Universal prophylaxis with entecavir is recommended in hepatitis B infection recipients and should be started perioperatively. Prophylactic treatment may be discontinued in selected stable low-risk recipients during maintenance immunosuppression. Reintroduce when the immune status is altered. All immunosuppressive agents in kidney transplantation can be used. Hepatitis B positive recipients, immunosuppression is intimately associated with increased viral replication. Thus, it is important to minimize the total immunosuppression virus. So, what I would show is an example of a patient, sibling transplant in 1992. Those days, we did not know that the brother was carrying the virus because we checked that. So detected transmission from donor to recipient, hepatitis B surface antigen positive, viral count remained very high. Using lamivudine 100 milligram, that was the only drug available in 1992-93. So yearly ultrasound of liver and kidney and alpha-fetoprotein estimation, unremarkable. Immunosuppression was initially with prednisolone, azathioprine and cyclosporin. You can see the viral load here, very high viral load. Entecavir currently is taking and he has got very good graft function, but he landed in another complication because of. I sent this for that a patient living with hepatitis B virus. I sent it to the journals abroad. They never accepted that. This is something, which we have to understand. Sudhantan said yesterday, some of the case reports, although they are interesting, they reject it. So we got it published that a man living with hepatitis C virus, a transplant more than 32 years now, he still has got high viral count. Now, hepatitis B virus, carrier state prevalence is seen in 4% of the population of India. Across treated and non-treated patients, the nucleoside analog treated patients had developed lung and pleural cancer, breast cancer, renal cancer, and colorectal cancer. So, tumors after kidney transplantation population study, kidney transplant recipient showed an overall risk of cancer that was about 3 times compared to the local population, with an overall risk of, for males of about double and for females over triple. Significantly increased risk in both sexes were observed for Kaposi sarcoma, lymphoma, and leukemia. So here is a patient, late post-transplant HIV infection, BK viremia, and allograft tuberculosis in renal transplant recipient with Kaposi sarcoma. He had secondaries, and he was treated with by an oncologist. And you can see, I have shown all the biopsies here. I can't go in detail. This is Kaposi sarcoma. He had supraclavicular lymph node showing Kaposi sarcoma, but this was subsequently treated, but he lost his graft. Let me take you that he had a second graft done, challenging male patient with retroviral infection on highly active antiretroviral therapy issues with retransplant. So he had a retransplant done in 2017. He's doing very well now. And we had so much complexity in adjusting his tacrolimus level because he required very little tacrolimus while taking the anti-rejection therapy. So this is the patient who has hepatitis B positive. He developed cancer of the rectum. You can see that the tumor sitting there, and these are the histological pictures of the tumor. So when you use nucleoside analogs, which he was taking, there is a risk of developing colorectal cancer. That's what happened to this patient of mine. So this is a rare malignancy. This is not reported. This is a patient who had kidney transplant in 2001, and she developed diarrhea and weight loss. And so we were looking for the common cause of diarrhea. And finally, since we have a cancer center also with us, we did a scan which shows that you have on the scan, there is a tumor sitting on the pancreas, head of the pancreas, and with the arrow. And we had an endoscopy done, and head of the pancreas was seen, and the needle was passed on to the pancreas, and a biopsy was done. And these are the results. It looks like a malignant tumor of the pancreas, which has not been reported before as a neuroendocrine tumor in a transplant patient 20 years after transplant. So metastatic neuroendocrine tumor in renal transplant recipient, and recipients of renal transplant are at increased risk of developing various malignancies, especially post-transplant lymphoproliferative disorder and skin cancer. Neuroendocrine tumors of the GI tract has not been reported in this setting. This is one of the early cases where they had neuroendocrine tumor in the liver. Our patient has in the pancreas. So antibody-mediated rejection, this is a mother to daughter done in 2022, good match, everything. But she had antibody-mediated rejection. And she was on dialysis, and then she got a second transplant, which shows TCR, ABMR, Banff criteria 2018. So you can see all the pictures here. This is a histopathology, this is a C4D, and segmental sclerosis and peritubular sclerosis. So as you move forward, you can see glomerulitis also here, and focal tubulitis as shown in the left-hand side picture. So clinical pathological correlation of transplant nephrectomies in elusive graft dysfunction. A common complication seen with 50 to 86% of kidney allografts is vesico-ureteral reflux, which in turn increases the risk of transplant pyelonephritis. So post-transplant graft pyelonephritis, these are some of the patients whom we had. This is a gentleman, diabetic, who received a deceased donor transplant, but he had recurrent UTI and also pyelonephritis. And these are the pictures showing this was transplant in 2020. You can see the recurrent pyelonephritis and also the sclerotic changes in the graft. Normal tubules, you can see that here, and you can see that he has developed diabetic kidney changes already 3 years after the transplant. This is a 59-year-old lady who gave the kidney to a deceased donor transplant. So this is something which we need to take into consideration. So mycobacterium tuberculosis, spousal renal transplant, and I will show you the picture showing it was non-caseating granuloma, but there was mycobacterium in the urine, mycobacterium tuberculosis. We had to treat him. We used rifampicin, which led to an acute rejection, and then we couldn't save the graft. Over a period of time, his graft was rejected, and we couldn't take it. So mycobacterium tuberculosis infection is infrequent in our country in the graft, but unless you properly look at them, you may have it, and you may miss it, and you won't treat it. So recurrent IgA nephropathy, this is a major problem I have seen. So what I do now is, rather, I go to the Japanese way. Here is a transplant recipient who had recurrent IgA nephropathy, did a tonsillectomy, and he is doing very well after the tonsillectomy. So this is something, he continues on his immunosuppressive medication. So tonsillectomy is one of the ways. I have done 5 tonsillectomies in IgA nephropathy, which was not responding to treatment, and they all had a remission of the disease. So transplant pictures of, this is inflammatory recurrent IgA in the allograft. This is the kidney picture, which is showing IgA nephropathy. So overweight and obesity is one of the other things which we see in our country. Serial EGFR body mass index and smoking predict renal allograft survival in South Asian patients. So this very clearly shows on the Kaplan-Meier graft survival curve for the allograft over 7 years of follow-up. So overweight plays, or obesity plays a role in the decreased graft survival. So kidney transplantation survival weight gain, there are 2. This is a lady who has gained so much weight, and this is another one who has gained so much weight. We advise them, that's all what we can do. And they eat and they gain weight. So what is the alternative to that? Should we resort to surgical and stomach reduction procedures, or give them the weight reducing drug? It is a question to be answered. Kidney transplant survival, this is something which we publish, and I want to show you that 40 to 60 years of age, above 60 years of age. You can see the color coding there, and up to 5 years, we have looked at that. The survival is not statistically significant between 40 to 60 and above 60. Above 60, 59% of them were diabetics. So patient survival is shown here between 40 and above 60, statistically not significant. And overall graft survival also shown here at the end of 5 years, 84% and 82% between the 2 cohorts. So hypertension. Are we controlling hypertension in our patients post-transplant? Are we getting adequate control? Every patient will go, my blood pressure is normal. I said, I need the number. And I have now instructed them, all of you buy a digital machine to check your blood pressure. So this is something which we looked at, and independent samples test for non-diabetics and also for diabetics. And you can see it here, the p-value between diabetics and non-diabetics, and independent sample test for left ventricular hypertrophy, no, and left ventricular hypertrophy, it is shown on this graph. So this is something which we need to look at that. In our patients, the majority of them develop post-transplant hypertension, or they do have the hypertension which continues after the transplant because of the immunosuppressive medication. And if we don't control that, they are going to land up in major cardiovascular situation. So immunosuppression monitoring and the Symphony trial, various trials of immunosuppression adequacy, Symphony trial, the OptiStep trial, the Transform trial, and they all suggest that we should have a tacrolimus level, which we are using now, of 5 nanograms per ml as the lowest level, irrespective of the date of transplantation. So it's shown here, the belatacept, we were involved in the trial. I don't know how many of you were involved in that trial. Then Astellas corticosteroid withdrawal trial, CNE to mTOR inhibitor trial, then CSA to everolimus at 4 months, GFR, there was GFR and acute rejection, then BUS trial. So these are some of the trials which were published. Balancing chronic alloimmunity versus chronic nephrotoxicity. This is a study which showed that 145 biopsies, 10 years, arterial hyalinosis, mesangial sclerosis, global glomerulosclerosis in 50 to 70% of biopsies with tacrolimus. So short-term control of alloimmunity is critical. Price to be paid is later nephrotoxicity. Early low-dose tacrolimus, first to 6 months, the C0 level 5, and with ACE inhibitor or ARB is equally beneficial with reduction of HIFTA. mTOR inhibitors to replace CNE for conversion, the results are mixed. mTOR inhibitors reduce skin cancer. Potential protective effects of mTOR inhibitors on malignancy, reduce 40% reduction in malignancy, mortality is 43% with mTOR conversion and versus inferior graft. So one has to look at, are we going to have an inferior graft survival or superior graft survival with an mTOR inhibitors? So now steroid withdrawal and MMF exposure practice in some centers in India. I know Sudan told me once, stop steroid. But I was speaking to Gabriel Danovich in one of the transplant TTS meeting in America. He said, Georgie, I will never take off steroids. And so I follow the same message. I am just going to contradict what you said. That was Gabriel's advice to me. So I have only very few patients who are off steroids. Majority of them are on a 5 milligram or sometimes 7.5 milligram steroids as a maintenance dose. So this has to be MMF exposure. Attempts to define appropriate dose, exposure have not been fruitful. OptiSet trial. Similar graft outcomes with CNI, MMF versus low-dose CNI / everolimus individualized therapy. Lack of data in graft survival or patient survival over time with MMF versus azothioprine. So long-term immunosuppressive management remains a balancing act for patient and graft survival and to minimize toxicity. The DD cell-free DNA, I am sure that Sudan is going to speak about that. That is donor-derived cell-free DNA gene expression profile, HLA matching, and DSA monitoring. Personalized approach to long-term immunosuppressive therapy, clinical endpoints at less than 1 year graft and patient survival, and 1 year rejection rates for new immunosuppressive therapy. So this is my most important patient. She was transplanted in 2020 years ago, more than 23 years now. Father gave the kidney to her. She was a school student, and we do not know bilaterally small kidneys. Father gave the kidney, and she was on cyclosporin, prednisolone, and MMF. And she joined medicine, became an MBBS, then did her post-graduation in medicine, got married. Then the question comes, once they get married, can they have a child? So I spoke to Professor Gaby Johnny. She's very keen to get pregnant. Johnny said, don't worry, Georgie, just switch her over to azothioprine. 2 years later, she became pregnant and she delivered normal delivery, healthy. I didn't change what Americans say, the cyclosporin. They said increase cyclosporin, decrease. Same dose, the cyclosporin levels were C0 were 20 to 25. I didn't manage anything. She just delivered a baby, and she is the second in the world pregnancy list. The longest one is in Italian registry, 270 months after transplant. This is 240 months after transplant. So in our country, we have to look at, don't follow what the Americans say that increase cyclosporin, decrease cyclo, the level is low. So here is a pregnancy after 20 years of transplant. Normal delivery, the graft function is fine, but she has 1+ proteinuria now. Serum creatinine is same, but I have started her on, that's the last slide. I have started her on ARB. So this is another thing, poisoned organ donation and allograft. I was discussing in the meeting, we use cobra bite victim for which a murder charge was made on me, and then I had to go to the court and to the police, and we had the cobra bite recipient living for over 22 years. These are the 4 transplants. So we have about 20,000 envenomation-related death in the country, and Vivek Gupta has done another one. And I think that this sort of pool, that is poisoned organ donor pool, is an important thing in our pool. So a memorable event organized by Professor Sanjay Agarwal in New Delhi in 2010. You can see Sanjay. Then you also have P.P. Verma and myself. Jeremy, you remember this? Jeremy, you are here. Jeremy is there. So 27th and 28th, the 6th World Organ Donation Day and the 1st Indian Organ Donation Day. So the thing, if there are no organs, no transplant. So we promote this, and let me come to the conclusion. Late graft loss is frequently and multifactorial. Mismatch in organ supplying and growing transplant demand, use of more marginal kidney for transplantation. Infection, see cardiovascular disease followed by malignancy, mortality among recipient patients. Patients older than 65 age doubled since, the transplantation, we have doubled it since 2001. Retransplant merit additional consideration for immune assessment. Young female recipients transplantation opportunity for pregnancy. I have shown recurrent de novo glomerular disease, bone and mineral disease require multitasking. Successful kidney transplant require a team-based approach. Utilize emerging biomarker protocol specified for immunosuppressive change, either to increase or decrease it. Surrogate endpoints, blood genomic profiling, molecular assessment of biopsy tissue, urinary chemokines, mRNA, and donor-derived cell-free DNA. These all we have to incorporate into our transplant program. Thank you for giving me this opportunity, and thank you for your kind attention.
Thank you so much, sir. Your comments?
Thank you, Georgie, for that overview of transplant and the complications and what we encounter and what we hope not to encounter in the field of transplantation. It's a vast topic, and you've sort of given us a bird's eye or even an eagle's eye view of what has happened. Thank you very much, George. The lack of time and being a presidential address, we will not be having any questions. So we end this session. Thank you.